NCQA has a mission to improve the quality of healthcare. And so our method to do that is to measure, because as we've heard several people say previously today and most recently Lisa, we can't improve what we don't measure. We believe in transparency. We think that our measures should be widely known what the details are. We want people to understand what they're being measured on. And that's really a key part of being acceptable to the delivery system and to providers, to know what exactly they're being measured on. And then finally, our model is one of accountability, because we believe that health plans know exactly who they're accountable for, and that once we are measuring and publicly reporting those measures, we can expect and track progress. So HEDIS is the name brand of NCQA, so the Healthcare Effectiveness Data and Information Set. These measures are used not only by NCQA, they're used very widely in different pay-for-performance programs, various settings, and we have more than 70 aspects of health included being covered in the HEDIS measures. And so access is just one part of that, but that's what I'm going to be talking about today. And then just to focus for a moment on the fact that more than 190 million Americans are in health plans that report quality results to us based on the HEDIS measures. So when we think about access in HEDIS, we are really looking at, does a health plan have the resources that it needs to provide care to all of its enrolled members, right? You or I could open up an insurance company and not have any doctors in it. And so that would clearly be a big problem. So the first couple of measures that were really focusing on access that were applied at the health plan level were from the CAHPS survey. And so we have items in both the adult and child survey that answer the questions about, did you get to have care when you needed it, and those kinds of things. The tricky thing, surveys plus and minus. A survey has a statistical power. We feel confident that it's an accurate depiction of a population, but it is a sample. And so it can never convey the experience of the whole panel or the whole population that's being measured. And so I think that's one of the issues that maybe we'll return to a little bit later. When we think about what was called realized access, so, not the perception of access, but did you actually see a doctor, then that's where we get to the utilization measures. And NCQA has a number of utilization measures. They're all from the point of view of the health plan. So looking at preventive health visits or annual dental visits, that's in the whole population. Looking, counting things that are happening among the whole population, then you can get into a more narrow population. And there you're looking for maybe a different kind of evidentiary basis for a measure, saying for pregnant women, did they have prenatal visits? Did they have the appropriate number of prenatal visits? Did they get their postpartum care? So that is one such specific population. And then I want to mention another specific population, because I think this is interesting, and it maybe goes along with some of the previous conversations about behavioral health, which is a measure of first-line psychosocial care for children and adolescents on antipsychotic medications. So we know that children should not be routinely prescribed antipsychotic medications. And this is a measure that says, before you start a child on an antipsychotic medication, did you at least try psychosocial care? Did they receive counseling? And so, again, this is really in contrast to did everybody in the population get an annual dental visit? And saying for this special population, this particularly high risk or particularly vulnerable population, did they get the care that they need where it's an issue where we know what the care they need is? So again, it still doesn't go to the quality of the care that they received, but it is maybe a necessary but not sufficient step to assure that they were able to access the care that's important to their health. So when we released measures July 1st, last week, we released a whole new volume of new measures. Every July, we release a volume of updated and some new measures. But throughout the year, we get queries in through our policy clarification system where people who are using our measures and have questions about how to use them are able to ask. And what is notable to me is that across our utilization measures, not a lot of queries about the population-based access. 20 questions about adult access to preventive care, 8 about the annual dental visit, a little more when you're getting into the population of folks who have alcohol and other drug abuse or dependence, and did they get the treatment they needed? So the IET measure looks at both initiation and engagement in that treatment. That's a little bit more. The really big number, though, 242, is around prenatal and postpartum care. And the reason for that is that the specification looks at people who are continuously enrolled for a certain period of their pregnancy. And because of state-by-state Medicaid regulations, people have varying amounts of coverage in their prepartum time and their postpartum time. And so that's not the reason for all of the queries, but for many of the queries, it's about how do I figure out who is liable to be in my denominator, and how do I figure out what can count for my numerator? So we're glad that we have these measures that are on particular populations, highlighting access to care for particular vulnerable folks, because we think that that's an important part of the package, as was referred to before. Kevin just mentioned, that you might have a suite of measures. You might only look at the high level at 1 or 2, but that there's a need for a delivery system to have a number of measures to use to look at their population. So I'm going to talk a little bit about the pieces of measurement that Lisa referred to. Validity is an important component of a measure. You have to know that the data elements are accurate and refer accurately to the thing that you're trying to measure. Then you also have the question, even if all your data elements are correct and are reliable, you have, in many cases, measures calculate a result, or they may use risk adjustment to adjust the result depending on the patient population or the characteristics of the population. So those are things that could introduce error into measurement. Actionability, I think, is really key, because you're saying we don't want to measure health plans on something that they can do nothing about. You have to be saying, this is something we expect you could change. We expect that you could do something about this. So that's really the key about this, is that there has to be something that is within their power to execute on that would change the result of this measure. And we are, maybe NCQA has a similar position to that of the Veterans Administration, in that we have a lot of feedback from the health plans that participate, just as the VA has a direct line to all of the VA system to get feedback on their measures. And I think that having that piece of taking note of what you expect the system could do differently is an important part to get that buy-in. And then next, I want to talk a little bit about meaningful differences, because this is something that is really maybe different depending on how you think about it. So when NCQA uses a measure to compare 1,000 health plans to one another, we are only looking for measures that will show a meaningful difference. Because if everybody was achieving 98%, it wouldn't be a very interesting story, and it wouldn't be a useful measure to distinguish optimal care. Now, That being said, I think we've heard in some previous panels today, that access may be a little different. Access, there could be a threshold effect that we want to say, if you got to 80%, then that's good, that's okay. So you might not be doing a comparative measurement strategy, but more of a threshold management strategy that you want to see all of the, you want all of the VA, you want all of the pieces of your delivery system to provide good enough care, and that should look like exceeding some threshold. So that's something that I think is maybe a little different in this particular area. And then when I think about the attitudes out in the world today, I would be remiss if I didn't mention that clinicians are revolting about the burden of measurement on them. And I think that is something that is clearly top of mind for an organization like NCQA. I imagine it's near the top of mind for other institutions. I know CMS thinks a lot about this. I imagine the VA has some concern about this. And I also want to mention that patients have to be considered too, because we see decreasing response rates for CAPS. We have to imagine that patients are tired of filling out surveys and that they're voting with their feet. And then the last thing that I want to mention is, because of the problems of surveys that I mentioned earlier, and health plans in particular do not like survey measures. It's very frustrating for them not to know who was it who had a deficit in their care. How could we incorporate patient-reported data to be better integrated into care systems so that the electronic information could be used for measurement, but it could also be used for care management or for pulling people back into care, or for outreach or case management, whatever you're thinking of, that it could be acted on in real time as well as used for measurement later. So with that being said, I just want to remind folks of Lisa's instructions at the beginning, that if you have a clarifying question, please put a message in the chat or add to the queue, and I look forward to the discussion as we go on. Thank you.
Great, thank you so much. Well, that was very interesting. So we really have gone from purpose and sort of frame of the measures. Now we're getting down to, how does the real world process those measures?